Hello everyone. Today we will be discussing about adult versus pediatric tuberculosis. Tuberculosis is a chronic granulomatous infection caused by Mycobacterium tuberculosis. India actually bears the highest global burden of TB, and TB is actually called as big three in global public health disease. So the other being HIV, TB, and malaria. These three constitutes the big three diseases of infectious diseases at a global level. And there are a lot of differences between adult and pediatric TB that basically arises because of the immune maturity, bacterial load, and also disease pattern. Actually, adult TB, in case of adult, they are the main transmitters. Okay. What is the difference? In case of adults, they will be the main infectious source, and the TB actually spread via droplets, and it has a high level of infectiousness. Whereas in case of children, they are usually infected from adults, and they have a low infectious rate, and also most of them will contract TB through a close household contact. This low infectiousness is due to the reason because sputum is usually swallowed by the children. Since the sputum is usually swallowed, they result in low infectivity. Now, pathogenesis. So usually the adult TB results due to reactivation of a latent infection resulting from reduced immunity. Whereas in case of children, the primary infection is predominantly due to a potential dissemination is predominantly due to the infection from adults resulting from potential dissemination to the immature immune system. So the type includes in case of adult, it will be pulmonary tuberculosis, which will be very common. Then because of high bacillary load and low dissemination. In case of children, extrapulmonary TB will be more common, meningitis, lymph node, and there will be low bacillary load and there will be high dissemination rate. That is, in case of adults, it affects the lungs predominantly, whereas in case of children, it affects extrapulmonary region. And in case of adults, there is low dissemination, meaning it is mainly about it mainly infects only lungs. Whereas in case of children, it is high dissemination, meaning it spreads to many parts of the body. Coming to the clinical features, in case of adult, there will be cough greater than 2 weeks, hemoptysis, fever, night sweat, weight loss, chest pain, and cavitatory lesions. Whereas in case of pediatrics, there will be low-grade fever, irritability, failure to thrive, persistent cough, weight loss, poor appetite, and reduced playfulness. So as you can see, there could be a difference in pattern in the existence of the clinical features. Now coming to the epidemiology, the source of infection is usually the index case, whereas in case of children, it will be always an adult case. There will be high infectiousness in adults, low infectiousness in children. It spreads through droplet infection, cough or sneezing. Only close contact with the infected adult can get it. It is often reactivation, that is post-primary TB, and it is usually primary infection. Now coming to the immune response, for adults, the cell-mediated immunity will exhibit a strong localized lesion, whereas in case of children, it will be immature and poor localization. There will be caesating granulomas, whereas here in children, it will be lymphohematogenous dissemination. Cavitation is quite common in adults but rare in children. Dissemination is uncommon in adults but frequent in children, frequently disseminating to CNS, bone, and abdomen. The organ specific, in case of children, in pulmonary TB, there will be chronic cough, breathlessness, and non resolving pneumonia. Lymph nodes, there will be painless, mated lymph nodes will be present. In case of miliary TB, there will be high fever and hepatosplenomegaly. And in case of meningitis, there will be vomiting and cranial nerve palsy. And skeletal, most it can occur any bone, but Pott's pain is the most common pediatric TB. The chest findings in case of pediatric TB it will be early, it will be silent, but there will be dullness, decreased breath sounds, endobronchial wheeze, there will be bronchial breathing, then there will be bilateral crepitation if it is a miliary tuberculosis. Radiological difference in case of adults, there will be cavities, fibrosis, and pleural effusion. In case of children, there will be hilar lymphadenopathy, primary complex, and miliary mottling. Diagnosis for adults is usually made through sputum microscopy, CB-NAT, chest X-ray, and MGIT culture. Whereas in case of children, it will be contact history, Mantoux test, chest X-ray, CB-NAT on gastric aspiration. Okay, this is quite important. And coming to the complications, it can cause fibrosis, hemoptysis, or bronchiectasis. Whereas in case of children, miliary TB, meningitis, growth failure, and skeletal TB. Long-term sequelae for children include, in case of pulmonary fibrosis and bronchiectasis, In case of neurology, there will be hydrocephalus, paralysis, then kyphosis, limb shortening, growth retardation, and anemia. So treatment includes, in case of intensive phase for 2 months, HRZD regimen and continuation phase HRE regimen. Totally 6 months in case of pulmonary TB. And the dose for adults isoniazid is 75 mg, but 50 mg in children. Rifampicin 150 mg but 75 mg in children. Pyrazinamide is 400 mg but 150 mg in children, whereas ethambutol is 275 mg and it is 100 mg in children. Tablets include, it is usually through weight band. So the weight is already divided into 5 categories: 25 to 34, 2 tablets, which comes in FDC stands for fixed dose combination, and 35 to 49 3 tablets, 50 to 64 4 tablets, and 65 to 75 5 tablets, and greater than 75 6 tablets. Very unlikely a patient will be having greater than 75 kg. In case of pediatrics, 4 to 7 kg 1 tablet, and 8 to 11 kg 2 tablet, 12 to 15 kg 3 tablet, 16 to 24 kg 4 tablet, and greater than 25 kg, then it will go to adult category. Okay. And remember, the dose is quite different. For pediatrics, this will be the dose, that is isoniazid, rifampicin, and pyrazinamide vitamins will be 50, 75, 150, and 100 mg. In case of adults, this will be the dose. Now, the individual drug doses, 5 mg per kg of isoniazid and 10 mg per kg of isoniazid in children. Rifampicin, it is 10 mg and it is 15 mg in children. 25 mg in adults and 35 mg of pyrazinamide in children, and ethambutol 15 mg and 20 mg. And major toxicity, isoniazid causes hepatitis and neuropathy. Rifampicin also hepatitis and orange color urine. Pyrazinamide will cause arthralgia and hepatitis, and ethambutol will cause optic neuritis. So coming to the prognosis, it is good with the complaints in case of adults, and it will be excellent with early diagnosis in case of children. That is why we need to do active case finding of close contacts whenever an adult is diagnosed, and a relapse possible if irregular regimen is there. Risk of neurological and skeletal sequelae if there is a delayed diagnosis. Coming to the prevention part, BCG is given at birth. INH prophylaxis for contacts of less than 6 years, and contact tracing is done by the public health department and national nutritional program under Nikshay Poshan Yojana. Every patient will get 1,000 rupees every month for 6 months under Nikshay Poshan Yojana for supplementing nutrition. So to summarize, in case of adult TB, it will be pulmonary and cavitatory. In case of pediatric, it will be extrapulmonary or primary. Infectiousness is high in adult, low in children. Diagnosis, sputum and CB-NET. Here it is clinical, radiological, and CB-NET. Cavities are common in adults. Dissemination is common in pediatrics. And fibrosis and bronchiectasis are common. Neurological and skeletal deformity is common. BCG has a minimal role. It is highly protective in case of pediatric TB. So adult transmit TB, children reflect recent transmission. Pediatric TB is extrapulmonary and possibacillary. Weight-based FDC improves compliance rather than taking 4 tablets. And adult TB control prevents pediatric TB. So BCG, early detection, NTEP compliance are key to elimination. Hope you have learnt. Thank you.